Please join me today in welcoming Dr. Lukse as she shares her insights and also her expertise today talking about neonatal head ultrasound. Thank you so much, Dr. Lukse, for being with us today.
Thank you. I appreciate that introduction, and I welcome all of you to this talk. I wanted it to be a review of neonatal head ultrasound, and hopefully everyone can get a little piece of something no matter where you are in your training or in your career. This is my first time presenting for Health for the World, so I'm a little bit clueless as to how many people are in training and where everyone is in their career who's attending. So thank you for the overview, and let's get started. I hope everyone can see my screen. Okay, so before we get into the nitty-gritty of imaging, there are a number of things that we need to consider regarding the practical application and practical preparation of the patient, including positioning. So very first thing that we always have to do is identify the patient. In the NICU, almost all babies are just as cute as the next one, so it's hard to tell them apart. So it's very important that you first look at the patient's identification, first and foremost, especially if there are twins in the NICU or in the nursery. Very, very important to make sure you have the correct baby and that you're doing the study, regardless of what type of study it is, on the correct child. Also, in the nursery and NICU, it's a team-based approach between the sonographer, the nurses, radiologists, and the pediatricians in terms of preparing the baby and positioning the baby. I've never had to use sedation for any head ultrasound, and we continue monitoring as per the nursery or the NICU. Now, one of the primary reasons that we need to do head ultrasound is for prematurity, but there are also a number of other reasons why you would do this exam. So you need to review the reason for the exam and if there's any prior fetal imaging. Sometimes there might be an abnormality on a fetal ultrasound that will trigger the need for a postnatal head ultrasound. It's also very important to know the patient's gestational age and also the adjusted age for prematurity. You should follow the hand washing and probe cleaning procedures as usual. And let's get into the nitty-gritty of head ultrasound. The advantages are that it can be done very early on in premature babies, and it's a very portable, quick, non-invasive bedside exam. There's no ionizing radiation, and we don't use contrast. It can be repeated as many times as you need. It can evaluate both anatomy and pathology to a certain extent. It does have its limitations that I'll talk about. It's a screening tool that's excellent for hemorrhage, specifically intraventricular hemorrhage, hydrocephalus, and periventricular leukomalacia. The limitations are that, of course, it's operator dependent. You want somebody who has done a number of these studies before. It requires an open fontanelle. There's limited assessment of the posterior fossa and the convexities. And there's limited evaluation for ischemia, any migrational disorders, and cortical dysplasias. But you can pick some of those things up, and then that could trigger the need for further imaging or further evaluation. So the way that we perform the study is using a transducer at the anterior fontanelle and taking images in the coronal and sagittal planes. We typically use a convex transducer for deeper structures and a linear one for superficial structures, such as the extraaxial space and the venous structures. We use both grayscale and Doppler evaluation, and sometimes you might use power Doppler, and I'll talk about that briefly. You can take supplemental images through other fontanelles, and this is an image of the fontanelles that we typically use. Most commonly, we use the anterior fontanelle right at the frontal portion of the baby's head. Occasionally, we'll use the mastoid fontanelle to better see the posterior fossa, and also the temporal window is a good way, as well as the anterior fontanelle, to see the circle of Willis. And I'll show you guys definitely more pictures on all of that. So, pictures are great, so I've included a lot of them. So for coronal images, you start at the level of the orbits, and the frontal lobes, and then you end up at the occipital lobes. So the very first image on a coronal view, you're seeing the orbital roof on both sides, and as well as the frontal lobes. You're seeing the falx in the centra. And the next couple images have both the grayscale and then the animated versions. So on the next set of images, what you're looking for are the lateral ventricles, right? And the cavum septum pellucidum, which is a normal structure in babies. And we will also talk about that. There's also the third ventricle. This doesn't delineate it that well. You have the sylvian fissures, and you're starting to see the temporal lobes. As you continue posteriorly, you're going to see more of the cerebellum, as well as starting to see some of the posterior aspect of the ventricles. And even more posteriorly, you start seeing the choroid plexus on both sides. Notice how echogenic the choroid plexus is on both sides, as well as the bone is very echogenic. Now, all the way at the level of the occipital lobes, you'll just see the parenchyma. On sagittal images, you start at the midline, then you sweep to the right, you go back to the midline and sweep to the left. So when we're starting at the very midline, there are a number of structures, normal structures that we're looking for. So you're looking for the corpus callosum, you're looking for the cerebellum, the fourth ventricle, and also the third ventricle. So these are the main structures that you're identifying before you start your sweeps to the right and to the left. So as you start your sweep to either side, there are a couple of additional structures that you're looking for. So on this view, you have the lateral ventricle, right? You have the caudate, which is delineated in red. You have the thalamus, which is delineated in green. And right at the junction where they meet, that is called the caudothalamic groove. And that is an area where you can find germinal matrix. And if that germinal matrix has had some injury, then it can bleed. You also see this echogenic area here, which you should not confuse for hemorrhage, and that is the choroid plexus, which is delineated in the pink color. Even more laterally, you'll start seeing the temporal lobe. Now, I just want you to notice the difference between the coronal views and these sagittal views. These are two different babies. So the first one had much more complex looking sulci and gyri, and that's because the first baby was a little bit more close to term than the second baby, who is a little bit premature. Okay, I mentioned that you can view both with the anterior fontanelle primarily, but also you can take additional views. So this is a transmastoid view. So you are imaging, and it's important for the tech or whoever's taking the images to delineate which side is up. So you have the supratentorial brain, and then here you have the infratentorial brain. So in this image, I want to point out you have the cerebellar hemispheres on each side, as well as the vermis. Then you have the cisterna magna here. Notice how echogenic the cerebellum and especially the vermis is. This is a normal finding. You don't want to mistake this for a cerebellar hemorrhage. So things like the choroid plexus, the cerebellum, especially the vermis, can appear very echogenic, and that is normal. Now, I mentioned this a little bit ago, but some normal variants and things that you should be aware of, and I'll mention these throughout the lecture. The complexity of the brain changes from a premature baby to term. So it gets more complex as the baby is closer to 40 weeks. So lissencephaly, or that smooth appearance of the brain, should not be diagnosed in babies less than 24 weeks. Very premature babies, you will just see the falx and also the sylvian fissures. The rest of the brain looks very smooth, but as you get more follow-up ultrasounds, you'll see that the complexity increases over time. So this is just a schematic of the brain or the sulcal development at 24 weeks, 30 weeks, and 40 weeks. And you can see how much maturation has occurred between the 24 and the 40 weeks. After looking at the general sulci and gyri, or the general contour of the brain, I look at the central structures, which include the ventricles. So we use the Levine index before 40 weeks gestational age and the ventricular index after 40 weeks gestational age. So the Levine index is for the babies who are not at 40 weeks. And so you measure from the wall of the falx to the lateral wall of the ventricle, all right? And you measure at the level of the third ventricle. So the lateral ventricles are the ones being measured, but you're just measuring at the level of the third ventricle. Now, when you're using the ventricular index, you're giving a ratio between the lateral ventricles and the biparietal diameter. Just some measurements to keep in mind. The cavum septum pellucidum should be about 3 millimeters or less. The third ventricle should be about 2 millimeters or less. If they start looking rounded, then you should perhaps mention that to the team, and they can, or we can look at that on subsequent images. Subarachnoid spaces are also something that we evaluate typically with a linear transducer, since that looks at the superficial spaces better. Sometimes patients will come in as an outpatient for macrocephaly or increasing head size. And we definitely do these images to make sure that there's no extraaxial fluid collection. There is something called benign enlargement of the subarachnoid spaces. So the normal measurements are done in a couple of different ways. So you can have an interhemispheric width, right? A sinocortical width or a craniocortical width. And all of those should be less than 5 millimeters. And that is within normal limits. Now, one way to distinguish subarachnoid spaces versus subdural spaces is that you have bridging veins within the subarachnoid spaces, whereas in a subdural space or a subdural collection, you do not have bridging veins. So at that point, you would put color Doppler on. So this is before we had color. It's a grayscale monitor. So in this image, you are seeing that the first image, there are bridging veins. So that's a normal subarachnoid space. In this case, you have this extra hypoechoic area that does not have bridging veins, and it's delineated in the red. So that is a subdural collection, or in this case, a subdural hematoma. So very important to distinguish the two in children. Sometimes you might be evaluating for things like non-accidental trauma or child abuse, and this might warrant a further workup. Now, speaking of fluid spaces, there are a number of normal fetal fluid spaces, and these include the cavum septi pellucidum, so which is at the level of the frontal horns, anterior to the foramen of Monro. So when you're measuring the ventricular index I mentioned, you don't include the cavum septum pellucidum. Cavum vergae is a term for the fetal fluid space posterior to the foramen of Monro, and then cavum vellae interpositae is at the level of the pineal gland above the internal cerebral veins. Do not confuse that with a pineal cyst or a vein of Galen malformation. Now, pineal cysts tend to have mass effect. Vein of Galen malformation will have color flow within it. Also, megacisterna magna and conatal cysts are additional fluid spaces that we should be aware of and not call them pathology. So let's look at some of these images. So you have on this first image, A, you have the lateral ventricles, and then right in the middle, that fluid space is a normal space, and that is the cavum septum pellucidum. Now, as that fluid space extends posteriorly, you can have something called a cavum vergae, which is seen on this sagittal view. And then even more posteriorly, you have the interpositum, cavum velum interpositum, which is at the level of the pineal gland, at the level of where the internal cerebral veins are. Just additional views, because I've seen this be confused for an arachnoid cyst or a pineal cyst. You really want to be aware of how it looks on a coronal view and on a sagittal view. Notice on the color Doppler view, there's no internal color Doppler. And there's no mass effect on adjacent structures. It's just tucked right underneath the posterior aspect of the corpus callosum. Also on these images, again, note how echogenic the choroid plexus is and also the cerebellum. Another incidental finding that we can notice, but I would not alert the clinicians or anything like that because it's really of no clinical consequence, are choroid plexus cysts. So there are little sub-centimeter cysts within the choroid plexus. There's no mass effect, and these will also resolve by about age 1 year. Now, conatal cysts are also within the superior lateral aspect of the frontal horns. Here is how they look on the coronal and the sagittal views. And this is the schematic of where you would find a conatal cyst versus an area with periventricular leukomalacia or cystic changes related to periventricular leukomalacia, and also where you might find a subependymal cyst. So the particular location is what is diagnostic of the conatal cyst. And this is something that will also resolve by age 1 year. So Doppler evaluation is performed through the anterior or the temporal fontanelles. The anterior fontanelle, you can see the full circle of Willis and also the internal carotid arteries very well. So you would perform both color Doppler and spectral Doppler. Then sometimes, if you need to, you might perform power Doppler as well to look for areas of hypo or hypervascularity. Now, when you're looking at the resistive index, it's important to keep in mind there's a wide age, and that's affected by the patient's age. So premature babies tend to have higher resistive index, closer to 0.9, because of the transition from the fetal to the newborn circulation. And as you get closer to age 2, the resistive index gets closer to 0.6 or 0.5, usually 0.6 or so. Now, there are pathologies where you can have changes in the resistive index. So in a premature baby, let's say if the baby has a lower resistive index, that could indicate that there's increased diastolic flow. Now, this could be from cerebral vascular dilation resulting from acute hypoxia or ischemia of any cause. In another baby, you might have a high resistive index, and that could be a little bit hard to pick up, especially since premature babies tend to already have a high resistive index. And that's due to decreased diastolic flow. For example, in cerebral swelling, where there's increased intracranial pressure that impedes cranial flow during diastole. That will increase your resistive index. Now, in patients with congenital heart disease, and most commonly with a PDA, the resistive index is unreliable. In patients with a PDA, the resistive index is elevated. This is just a very brief overview of the Doppler evaluation, and really for the cranial ultrasounds, we do limited evaluations of it. So these are just some images of the circle of Willis on a coronal view. Okay, this is done through the anterior fontanelle. We can evaluate the waveforms and look at the resistive index as well. And then you would also look at the superficial veins as well as the superior sagittal sinus by evaluating also through the anterior fontanelle and seeing that there's continuous flow throughout the cardiac cycle. Now let's talk about some pathology. The most common things that we can evaluate on head ultrasound are hemorrhage, right? Periventricular leukomalacia. I really like it for hydrocephalus, and occasionally congenital malformations, but specifically the ones that are midline and predominantly supratentorial are the best ones to evaluate for. Things that I mentioned earlier, you need to know the patient's gestational age. It's also important to know the birth weight, because some of these pathologies, actually most of these pathologies, aside from the congenital malformations, occur more frequently in patients who are low birth weight and also who are preterm. There's a link to prognosis. So if there is a finding that's pathologic, there's worse prognosis in preterm babies typically. So premature infants less than 32 weeks and weighing less than 1,500 grams are at increased risk of intracranial hemorrhage. The germinal matrix is at the caudothalamic groove. It can also be found in the remainder of the ventricles, and most of the hemorrhage occurs in the first week of life, typically in the first 24 hours. Along with premature babies, the babies on ECMO are also at increased risk of hemorrhage. Now, germinal matrix or intraventricular hemorrhage is graded from 1 to 4. So grade 1 is when it's limited to the caudothalamic groove. And I'll show you images of all of this. Grade 2 is when there's intraventricular hemorrhage, but the ventricles are not dilated. Grade 3 is when there's hemorrhage into dilated ventricles. And then grade 4 is when there's involvement of the brain parenchyma. So the risk of mortality, neurodevelopmental disabilities, permanent shunt placement increases with increasing grades, specifically with grades 3 and 4. They have increased negative outcomes. So this is an example of a sagittal view and a coronal view at the level of, on the sagittal view, you're looking at the caudate, the thalamus, you're seeing the choroid plexus, seeing the lateral ventricle here, and you see a focus at the caudothalamic groove that is very echogenic. And since that's limited to the caudothalamic groove, that is a grade 1 germinal matrix hemorrhage, and we can confirm on the coronal view, you see that it's on the left side where you have an extra echogenic focus. Symmetry is your friend, but it can also lead you astray in areas like hypoxic ischemic encephalopathy. So, but in terms of hemorrhage, symmetry is your friend. Now with grade 2 hemorrhage, you see that there is involvement at the caudothalamic groove, but there's also this extra echogenic focus that's in the dependent portion of the lateral ventricle, separate from the choroid plexus. Right? Remember, the baby's lying on its back. So this is in the dependent portion. And so this is a grade 2 intraventricular hemorrhage. Okay. Grade 3 intraventricular hemorrhage is when you have hemorrhage within the ventricles and the ventricles are dilated. Notice the very smooth appearance of the brain. So this is in a premature baby. So there's clot within the lateral ventricles and also within the third ventricle here, and the ventricles are dilated. Now with grade 4 hemorrhage, when you have involvement of the parenchyma, it can look very, very messy. The areas can look very echogenic, and it almost looks like a snowstorm right in the middle of the brain. So this is grade 4 hemorrhage. We can also evaluate for periventricular leukomalacia, which is basically white matter injury due to a number of causes. Now, this is also graded as grades 1 through 4. Grade 1 is when you have periventricular echogenicity lasting more than 7 days. Grade 2 is when it develops into small periventricular cysts. Grade 3 is when there's extensive periventricular cysts, especially in the occipital and frontoparietal regions. And grade 4 is when you have extensive subcortical cysts. And as you can imagine, the higher the grade, the worse the prognosis. Okay, this is an example of periventricular hyperechogenicity extending beyond the 7 days. Unfortunately, I don't have any images of the cystic changes, but I did want to mention, again, some of the normal echogenic areas that you want to be aware of that you don't want to call pathology. So those include the choroid plexus, the vermis, echogenic caudate heads, the anterior limb of the internal capsule, and optic radiations at the level of the occipital lobes can all look very echogenic. So do not call those pathology. If you're unsure about it, you can look at particular images, look at an atlas for anatomy, and see what normal anatomy is supposed to look like over time, from premature to term infants. Now, another area that is sometimes confused for periventricular leukomalacia are these white matter halos or pseudolesions. And it's due to the anisotropic effect because there are white matter fibers at 90 degrees to the transducer. So the way to tell this apart from periventricular leukomalacia is that if you change the angle of the transducer, this will not be apparent anymore. And typically it's not seen in 2 separate views. Also, this area is less echogenic than the adjacent choroid plexus. So this is just basically an artifact that's caused, and it's called a white matter halo or pseudolesion. Do not call that PVL. Again, a lot of our reports are very important for prognosis and also for treatment. So we also don't want to make a diagnosis that isn't true, since that can affect this person for the rest of their life. Now, another area that you need to be aware of that that can be seen as lenticulostriate vasculopathy. It's a very non-specific finding, and this will typically go away after the first month of life. Okay. You see that branching pattern of increased echogenicity in the region of the basal ganglia, and that is diagnostic of the lenticulostriate vasculopathy. All right, I have a couple of cases, and I'm not sure how you guys do this. Do people take cases, or do you want me to just go through it? Dr. Maria, do you want to just chime in about that?
I think we have never had like interactive ones, so maybe you can go through them, or if someone
Okay,
is
sure.
brave
Yeah,
enough to go and take one case, it's good for us. Like we still have time, so it's okay.
Okay. So this first case is a full-term newborn with an abnormal prenatal sonogram. As I mentioned before, gestational age is very important. Knowing if it's full-term, preterm, ideally you would know the exact gestational age and also why we're doing the study. So the prenatal sonogram was abnormal. We have a coronal image, okay? And now that we know what normal structures look like, we can make diagnosis about pathology, right? So on a coronal view, at the level of the lateral ventricles, there are a couple of structures that we're supposed to see. So we're supposed to see the lateral ventricles and the cavum septum pellucidum, right? Now, this is an abnormal configuration of the lateral ventricles and the cavum septum pellucidum. The cavum septum pellucidum area looks very dilated, and you also have some dilation of the temporal horns. Okay, so now on a sagittal image, so this is slightly oblique, but on a midline sagittal image, you're supposed to see the corpus callosum, right, and the cerebellum and the fourth ventricle. So in this case, I'm not seeing a normal corpus callosum, and I'm seeing dilation of the ventricle, and it is dilated, more dilated posteriorly than anteriorly. So ultrasound, head ultrasound is a screening tool, and they can do further imaging, and that was what was done in this child. So these are sagittal and axial T2 images. So basically, for those who are a little bit unfamiliar with MRI, T2 images specifically look at fluid. So CSF is a type of fluid, right? So you have the fluid spaces. Let's identify some normal structures. So here you have the cerebellum, you have the brainstem, the fourth ventricle, the cisterna magna here, and then you have the supratentorial brain. Now we're at the level of the midline sagittal view, and we're missing a structure. And that structure is the corpus callosum. And this is just confirmed on the axial views. So this is agenesis of the corpus callosum. Now, I just want to show you the different views. You can make out different patterns, right? On an axial view, you would see the parallel ventricles and the colpocephaly. Colpocephaly basically means that the posterior aspect of the ventricles are more dilated than the anterior aspect. Now, on a coronal view, you would see the steer horn ventricles, and on a sagittal view, you would see the sunburst appearance. Depending on when the insults occurred, if you have an insult occurring between 10 and 12 weeks, you have complete agenesis of the corpus callosum. If it's between 12 and 20 weeks, you have dysgenesis, and after 20 weeks, it's hypoplasia. So this is an example of agenesis, right? So you have complete absence of the corpus callosum, right? The steer horn ventricles on the coronal view. This is what's called a race car. I mean, you can use your imagination to hallucinate whatever you want. The sulci and gyri are oriented in what's called a sunburst pattern, basically radiating away from the midline. This is an example of dysgenesis where part of the corpus callosum is absent. So this is when the insult occurs between 12 weeks and 20 weeks. And then you have hypoplasia where you have a thinned corpus callosum, and sometimes you'll have bowing of the corpus callosum and dilation of the lateral ventricle as a result. And this is an insult occurring after 20 weeks. If you were to do diffusion tensor imaging, this is a normal corpus callosum with the crossing fibers, and then patient with agenesis or dysgenesis of the corpus callosum, you would be missing those crossing fibers. So it can be in isolated findings or associated with other midline abnormalities, including Dandy-Walker spectrum, Chiari-2, holoprosencephaly, septo-optic dysplasia, and Aicardi syndrome. The next case is a full-term 12-day-old male with seizures. Now, I'm showing you some cases that are different from what I've reviewed because I want you to see the more wider spectrum of the utility of head ultrasound. And I find that it's more straightforward to pick up, grade 1, grade 4 hemorrhage than some of these congenital abnormalities. So again, a full-term baby who's now 12 days old having seizures. So one thing to note is that with intraventricular hemorrhage and PVL, in premature babies, even if they're not clinically apparent, you would do a baseline head ultrasound. Whereas in full-term babies, you may not necessarily get a baseline ultrasound, but if they do have clinical symptoms, then a head ultrasound would be valuable. So in this baby, again, we have to know normal structures to identify pathology, right? So now you guys have seen some normal coronal ultrasounds, and you can see that these lateral ventricles are a little bit more rounded than we like, as is the third ventricle. The temporal horns are also dilated, right? And there's all this echogenicity in the parenchyma, especially surrounding the third ventricle and along the periphery of the lateral ventricle. We get some additional images. So this is a sagittal view. So on a sagittal view, we're supposed to see the corpus callosum, the cerebellum. This is slightly angled. So in this case, you're seeing a larger retrocerebellar CSF space and a very small cerebellum. Okay, so when you put, and also the periventricular echogenicities. So when you put these things together, this is an example of a torch infection, and the most common being CMV in the United States. So CMV, congenital CMV is the most common intrauterine infection through transplacental transmission. You can get microcephaly. Most patients who have a positive CMV titer have normal head ultrasounds, even if they have neurologic positive neurologic clinical exams. But in patients who have positive head ultrasounds, the things that you would find are the periventricular and parenchymal calcifications, the cerebellar agenesis or hypoplasia, ventricular dilation, and a thinned corpus callosum. So in this baby, we had a couple of those findings. So we had some ventricular dilation, the periventricular calcifications, right, thinned corpus callosum, and cerebellar hypoplasia. Okay, now case 3 is another full-term female with an abnormal fetal sonogram showing a neural tube defect. So we have midline sagittal view as well as a coronal view. So on the sagittal view, we are seeing the echogenic cerebellum, right? We're seeing the lateral ventricle. On the coronal view, you're seeing a little bit, it appears that the lateral ventricles are dilated, and you have what's called a dangling choroid within the lateral ventricle. Notice how echogenic the choroid plexus is and the cerebellum, okay? So in this case, I don't think that head ultrasound is great for making the diagnosis. You can see that there's ventricular dilation, but what else is going on? Remember I said that the posterior fossa is not well evaluated on a head ultrasound. It's typically the ones that are done through the anterior fontanelle. So in this case, the baby had further imaging, and it was found that there was low-lying cerebellar tonsils, ventricular dilation involving the lateral and third ventricles. And when we did the spine MRI, right, on T2 and T1 images, you see that there is a posterior spinal defect through which there's a sac and the spinal cord and nerve roots exiting through, all right? So this is an example of a Chiari-2 malformation. because you have both spina bifida and the low cerebellar tonsils, and this can also result in hydrocephalus, which we saw in this child. All right. Another case, and I believe this is my last case, this is the 5-month-old with an abnormal head shape. So when you get closer to the 5 and 6-month mark, the fontanelles are starting to close, and then you don't have a great acoustic window. So I do not generally, I'll try to do the head ultrasound on a 6-month-old, but it can be of limited diagnostic value. Of course, it's useful for things like hydrocephalus and some midline abnormalities, but MRI might be more useful as you get a little bit older than 6 months. So this baby has an abnormal head shape. Now we're at the level of the frontal lobes, at the level of the orbital roofs. So you see that there's asymmetry between the right and left orbital roofs, with the left side appearing slightly elevated compared to the right side. Can you smell what the rock is cooking, right? Some of you might get that reference. So the correct study to do for abnormal head shape is a CT. All right. So CT evaluates bone very well. And if you don't have CT available, you might start off with an X-ray. All right. We do start off with an X-ray. Head ultrasound is not the first modality. I'm just showing this is an interesting case. You would start off with a skull X-ray in multiple projections, and then if needed, specifically if neurosurgery asks us, we'll do the head CT and do some 3D reformats. So in this case, we see that there is closed coronal suture, right? So you have the anterior fontanelle here, and as well as the asymmetry of the orbit and the left frontal bone. So in this case, this was unilateral coronal synostosis, which was picked up starting with the head ultrasound, and you get the harlequin appearance of the left orbit, left frontal bone, plagiocephaly. I lied, I have one more case actually. So we're still doing good on time. This was a case of, I don't actually have the background clinical information, but on this coronal image of the head ultrasound, you see that there is the slight tenting of the frontal bones, right? And then this baby also had an X-ray of the hand, and this has a mitten appearance. There's fused soft tissues, and then underlying that, there are fused bones as well, right? An abnormal orientation of the thumb, fusion at the distal phalanges. So putting these things together, right? They did further workup, and you can see the 3D images. You see bilateral coronal synostosis, 3D views of the hand. I don't think that was really necessary. And also the skull base. There's fusion of some sutures at the skull base. So this syndrome, if any of you know this, is associated with hearing loss. Okay, this is Apert syndrome. So the findings are craniosynostosis, you have syndactyly, hearing loss, and midface hypoplasia. All right, some of the articles that I looked at, especially these first two about cranial sonography, some of the pitfalls and variants I found very useful. I also got a bunch of the images that were color-coded from radiology assistant. So please use those as reviews for yourself. And thank you so much for allowing me to speak and share. And if anyone has any questions, I'm happy to answer.
Thank you so much, Dr. Lukse, again for joining us today for this wonderful topic. I know it's always fascinating to have some ultrasound that it's nowadays kind of in the backseat. I don't see questions so far, but if anybody has question, you can put it in the chat or you can put it in the Q&A section, and we will solve them with Dr. Lukse.
And I know there's an international audience, but also regarding head ultrasound, it's probably one of the more common things that private practice radiologists reach out to me about. So residents who have left and gone into private practice who read a variety of studies, or attendings who are mostly reading adult studies, but then on weekends they'll look at fetal head ultrasounds. Of course, you're going to be a little uncomfortable with just reading things maybe once every few months, right? So they often reach out to me about these types of studies. So somebody
Uh,
had a question.
I have a question also. Do you also have techs, right? Or do you do the head ultrasound yourself? Or you have the tech who goes to the NICUs through the day and then you get the images?
Right. So we have
Sonographers.
ultrasound techs who do these studies. These are usually scheduled. There's occasional time periods when they'll ask us for a stat ultrasound on the weekend or overnight, but usually these are pre-scheduled and
Oh,
they'll do them in batches. Yep.
and is it for like general peds or is it for neuro peds? Because when I did my training in
Uh-huh.
peds neuro, they were done by the body radiologist, not by the neuroradiologist.
Right. So
I
this
mean,
is
all
general
three.
peds. We just have a neuroradiologist here who mostly do adult radiology. So I'm the person for
Okay.
most of that. So it does come over to us.
Okay. Great.
Yeah.
So
And
the first
there
question in the chat is gestational age upon delivery or last prenatal ultrasound?
gestational age upon delivery. Yeah, so gestational age is determined at the time of delivery, and then depending on that age, then the prenatal ultrasound, let's say you're doing it 2 weeks later on a 24-week baby, then the adjusted age would be 26 weeks, right? So when you're looking at the atlas, you're looking based on the gestational age.
Okay, great. So second, we have Dr. Bermudez. One of the more difficult issues in ultrasound is to differentiate between normal white matter and a stroke or edema zone in the premature newborn.
Yes, so that is definitely a big limitation of cranial ultrasound. Things can look very symmetric, especially in hypoxic ischemic injuries and also in stroke. So hypoxic ischemic injuries, you'll see increased echogenicity in the basal ganglia, the central white matter. And then with strokes, you might see it more in the periphery. And as you saw in some of these images, there's a lot of artifact along the periphery because you don't have the best acoustic window. And so you can miss a lot of that. And sometimes people are not paying attention to the periphery so much. And so I've seen strokes missed, or there's a delayed diagnosis just because this is not the best modality for that. Every uh, type of ultrasound has its limitations, I think. So it really depends on the clinical findings and clinical suspicion.
Okay, thank you so much. We have three more questions. So, Dr. Okran, do you do transcranial Doppler ultrasounds commonly? At what age are these students not of diagnostic value?
So I assume he's talking about TCD, so transcranial Doppler. I talked a little bit about Doppler evaluation in the preterm babies. So transcranial Doppler, we typically do for sickle cell patients to screen for abnormalities and maybe increased risk of thrombotic events, right? Or abnormalities within the intracranial arterial system. So we try to do it in basically patients up to age 16 or so. In a lot of them, especially after age 10, it can be very limited, but we do attempt it, right? I usually don't say no. The sonographer will come and let me know if the images are very limited, and I'll take a look at it myself. But we always give it a try. I don't have a strict cutoff for age for no longer doing transcranial Doppler. And then, of course, if the peak systolic velocity, based on, we still use the stop criteria, if it's greater than 170 centimeters per second, then they may warrant additional imaging with either with a CTA typically.
Okay, thank you. So Additional question, is bilateral mastoid view part of your usual scanning?
No. So majority of the patients, the ultrasound techs obtain the images through the anterior fontanelle. Now, if we know that there is, let's say, prenatal ultrasound showing a posterior fossa abnormality, then you might direct the ultrasound tech, or you might go yourself to use the temporal window or the mastoid fontanelle. But that is not a typical protocol.
Okay, yeah, I remember I was a sick kid, so we used to do mastoid in couple patients, as you say, like not like routinely.
It's not routine, no.
Yeah. So we have two more. Which index is important in hydrocephalus for surgical interventions?
Yeah, so we would use the ventricular index for surgical interventions.
Okay, perfect. And I think the last one, I don't see any more questions. What is the ideal ultrasound probe to use for the procedure and what are acceptable alternatives? Thank you.
For
The
are
probe
they
for the
talking
ultrasound.
about for okay, just in general for head ultrasound? So we'll use a convex probe for imaging through the anterior fontanelle, and basically that gives you a full view of the brain, right, from top to bottom or from anterior to posterior. And then if you're looking at the superficial structure, so for example, in babies that you're looking for superficial hemorrhage, or for looking at patency of the dural venous sinuses, then you would use a linear probe.
Okay. Do you use the mini convex probe or
Yes, so it's a
the bigger one?
C58. Yeah,
So,
C58 probe. Yeah.
okay, perfect. So we have another question. We still have a bit of time. So how should we expect the appearance of germinal matrix hemorrhage to evolve over the weeks and months after?
Yeah. So germinal matrix hemorrhage, um, basically it depends on the grade, right? So grade one will basically can become cystic, right, at that area. And so sometimes in babies, you'll just see a little cyst there. Grade two and three, the clot itself will start to retract. So you'll just see like little echogenic masses, right, or heterogeneous appearing masses sitting within the lateral ventricles. And then grade four, it can progress just like you see with any sort of parenchymal injury into cystic changes, encephalomalacia, and so forth. So that's why babies with grade four hemorrhage have much worse prognosis than a baby with, let's say, grade one hemorrhage.
Okay. Additional question. Is it okay to use TB probes like transvaginal probes, I assume, is it?
So I have never used that, but you know, the array is very similar. So if you can try it and let me know how it works. I have not tried it myself. It's not
I,
something
I
that's
remember
readily,
I
yeah,
remember we used to try it at home when like back in Colombia someday we don't have the mini probe and the regular convex tends to be so big, so the
right.
transvaginal one works pretty well.
Yeah. So
I must admit it. Yeah, it
I'll
works
tell
really
you, for our pediatric machines, we don't even have that probe sitting at the machine because we don't use that in pediatric patients, right?
that's
Most of
true.
them are
Yeah, we
not
have it.
sexually active. We just do a transabdominal pelvic ultrasound. So it's not even available on our machine. So yeah, I think if you don't have the specific C58 mini probe, then by all means use the resources that you have. So
Exactly.
yeah.
Yeah, actually the chat says Dr. Rocha Ritual. We use it here in Philippines. Thank you. And I
That's
think
so
we have one
interesting.
more.
I'm learning so much. That's really interesting.
Yeah, we have one more question. It's how often do you follow up the germinal matrix ultrasound? Sorry, hemorrhage.
Okay, so it depends on the degree of hemorrhage, but usually it's there's a baseline, right? And then there's weekly ultrasounds, but it can vary. There's no I wouldn't say I've noticed like a set protocol from the NICU, but it can also vary depending on your institution. But I think every week or every 2 weeks is until term is a good parameter to have.